Thank you to the organizers and for everybody who's staying late into their afternoon on a Friday. Appreciate your attention. I'm coming to you from Bethesda, Maryland, so a little bit later here. And I just want to apologize if you do hear dogs in the background because it's Friday evening. I thought my husband was going to be home to take care of them, but he got stuck at work. So hopefully they won't bark. I'm going to talk to you tonight about some of the work that we've been doing using tech enablement to support community-based trials. And when I say community-based trials, this is really about working in communities that have typically been ignored, underserved, and not addressed by clinical research, whether it's clinical trials sponsored by industry or whether real-world evidence studies where we're not really taking into account a lot of the populations where we know that the burden of these diseases looms larger than in many of the people that we test. So I'm going to, share my screen. Okay. Hopefully you can all see that. And I wanted to open with this to say that I think we finally reached a point in the technology space where we can begin to build incredibly flexible and just-in-time tools. And I think many of you are beginning to experience this in your consumer life, whether it's Netflix or whether it's an airline travel, which is the example that I put up here. Namely that we're not necessarily going to be stuck in a situation where we have to build natively coded mobile applications for each study we do. Rather, we can begin to leverage technology that allows us to go through one single application and support multiple studies and multiple programs through a common portal using configuration and very low code or no code solutions. Much of this has been enabled by the development of things in the cloud-based architecture. We're currently using something called event-driven architecture, as well as some of the novel AI strategies. So that data that's flowing in when we build these interfaces that are connecting to patients out in the field or to community health workers, study coordinators, nurses, doctors, what have you, things can be automated. And every time we do updates or we make changes, we don't have to go back to the well, recode, and then have everyone involved upgrade. And this has been really, really an important development, I think, that's going to take these tech-enabled approaches to the next level. I firmly believe that the places that we're going to really see AI and tech enablement make a huge difference out of the gate is going to be at community health providers, academic centers, but really our ability to touch and engage with communities that haven't been engaged previously. So I'm the CEO and founder of a company, RespondHealth. We are a real-world evidence company. I've been an evangelist for many years while at FDA and prior about the importance of understanding multiple dimensions when we do clinical research, whether that's interventional clinical trials where we're testing novel therapies, or whether it's observational studies or natural history studies. In any case, we really need to understand more of the dimensions of what's going on with people as they're moving through our research programs. And this includes not just the stuff that we're picking up in the clinic, but things that are happening to participants or patients between visits. This is very, very critical for underserved communities because underserved community members typically don't have a primary care physician or all their medical records in Epic. They are typically engaging the healthcare system in various places. It might be in the emergency room, it might be in a pharmacy, it may be at a clinic, but it's certainly not managed in the way that we think, oh, we can get data and we can touch these people through one primary contact. This is just an example of some of the programs and people, foundations, companies, academic institutions that we've worked with. We've worked for many years at scale. We have, hundreds of thousands of people now that have been involved and touched our platform. Certainly more than 28 platforms launched at this point, multilingual. And one of the things I want to point out is we really worked hard at the beginning to think about how to engage patients and understand and learn from them what would make tech easiest for them. And as importantly, engaging people on the front lines of healthcare about what would make tech easy for them. And that has resulted in us having a 93% participant retention rate in studies that are lasting upwards of 5, 6, 7 years, which is quite incredible at scale, as well as 86% data completion rate. This is much higher than most of the decentralized trial solutions that you may see supporting clinical trials right now. So I thought I'd talk about a few examples of the work that we've been doing. And unfortunately, given the time, I'm going to go rather quickly, but hopefully you'll be able to get a sense of what we've been doing. This is the first project that we ever did as a company. It is in Brownsville, Texas, which is a border city, recently made famous by visits from both presidential candidates. What we were engaged in doing was creating a tech-enabled system that would allow promoters and community health workers to engage patients where they are and to support doing diabetes education programs, monitoring of vital signs, and educational programs that included fitness classes, nutrition classes, et cetera. And the trouble here was that many of these patients were presenting with type 2 diabetes, hyperglycemic events in the emergency room, and they weren't getting scheduled for follow-up visits in federally qualified health centers for up to 3 months. And so there was this gap of care and of education that existed that the University of Texas program, using community health workers and promoters, decided to try to fill through a strategy that was creating programs at scale where you could bring people in, identify them at federally qualified health centers, emergency rooms, or events that they sponsored, giant Zumba classes or other things, and begin to engage people in a diabetes management program. When I say at scale, we've been at this for many years now, and we have in our system right now 21,000 people for over 6 years. And this program is being expanded countywide in the Rio Grande Valley. The other important thing to note is this is an example of where type 2 diabetes studies have not reached the place where the burden exists. This is primarily a Mexican culture. The rate of type 2 diabetes in this group, in this community, is 37%, starting at age 9. So this is a significant public healthcare burden with extreme unmet needs. The good news is these programs work. And I put up some of the demographics so that you can see this is not the typical patient that's engaged in a clinical trial for a GLP-1 or for a novel diabetes therapy. These are patients who have, have not necessarily employed, are uninsured often, and have mean A1Cs of 10.2. If you look across all of the clinical trials that have recently been conducted in the drugs you're all hearing about, Ozempic, Wegovy, Zepbound, Mounjaro, the average A1C starting point for those trials was 8.2, not 10.2. And the average reduction that's been seen across all those trials is between 1.3 and 1.5 of A1C. Well, if you look here, we're getting there. And not only are we getting there through these education and educational programs and access to nutrition classes and healthcare between visits, we're sustaining this over time. This is over a period of 2 years, a significant reduction in A1C. And I just wanted to give you a sense of the population we're working with. This is a class, a Zumba class. We track every person that come in to these classes and events. We capture all the vitals, and this is one of our community health workers. This has been a very, very rewarding program for us, and we're currently in the process of expanding into other areas in Southern Texas. Next, I want to tell you about a program that we've done with the University of Buffalo, Mount Sinai, and State University of New York. The problem was, how do we deal with hepatitis C virus eradication in communities, again, where the burden is largest? And those communities are people with substance use disorders, primarily IV drug users. Now, we knew at the get-go that The challenge with the HCV therapies, whether they be Harvoni or Salvati, is that they require compliance for 6 to 8 weeks. Working in a community that obviously is going to have challenges with compliance. On top of that, we need referrals and we need infectious disease doctors to be part of the program for managing these medications once they're prescribed. So the idea here was to create a model that was tech-enabled and connect these 3 academic hubs to 12 methadone clinics across the state of New York, and essentially do all of the patient management with ID docs in the background and brought in to meet with patients via telehealth, but support them through this journey of 6 to 8 weeks in order to eradicate A1C. As you can see, this data has just come out. This has been incredibly successful, more than we anticipated, in that when we looked at the usual care arm, which included referrals to infectious disease doctors with multiple follow-up calls from the methadone clinics, we had 35% of the patients complete their hepatitis C drugs. However, when we used the tech-enabled strategies where social workers became the front lines and where we provided them with tools that enabled them to track and manage patients as part of this study, we had 90% of the patients complete their hepatitis C program, medication program. Additionally, there was a statistically significant reduction in substance use in the patient that was in the tech-enabled social worker front arm. This is just an example of some of the tools that we put in the hands and tablets of the social workers at the methadone clinics, where previously they were managing everyone in their community pretty much on paper. And so again, we're excited about this because we feel like the tech is allowing us to create a scalable approach that we know works and that we can take to other places to help combat the terrible high rate of hepatitis C virus in this community. Lastly, I wanted to talk about how we took these strategies and we used them in a clinical trial of an infectious disease with a pharmaceutical company. And here the problem was a different form. It was we needed to catch patients early in their disease. We needed to catch kids when they first became symptomatic with RSV, get them tested, and get them enrolled for a novel antiviral. And this is so challenging to do in current pediatrician. Patient comes in, presents to the pediatrician refers them to a site where the study is happening. It was so challenging that the company set up 150 sites across the country to recruit 150 patients with recruitment goals of 1 patient per year per site. So what we did was take a different tack. We created a technology that was a parent education and symptom tracking tool. And we launched this through messaging, through electronic medical records from the sites that were involved in the study. This technology included videos, information about RSV, when RSV levels were coming to the geographical area that participants were in, and handy tools here that had an algorithm in the back such that when the kids reached a certain number of and significant level of symptoms, this triggered a geolocation and allowed us to refer those patients in for rapid RSV testing, screening, and consent via the mobile technology. The success of this was such that within 6 weeks at one site, we had 36 children screened and 6 enrolled, as opposed to 1 patient per site per year. Unfortunately, this study was stopped because COVID came on board and no infectious disease clinical trials, obviously, or respiratory trials were able to be conducted during the pandemic. And so that actually was the predecessor to a bunch of work that we did at scale in COVID, where we took an approach of symptom tracking at the beginning and did multiple rounds of evolution of the technology. As you recall, the symptoms kept changing over time before we had testing. Then we added testing programs and we added vaccine tracking programs, starting initially with Drexel University and Quinnipiac University. And at Drexel, building with funding and support from the Bill and Melinda Gates Foundation, one of the few domestic programs that they funded, to be able to do a COVID testing program and a COVID tracking and follow-up program in a community North Philadelphia and West Philadelphia, where there were no COVID testing centers. So we stood up the only testing center that was in the area. We had community interventions and community health workers. We worked very closely with the Children's Hospital that has about 50% Medicaid patients. This is primarily African American and Latino neighborhood, again, underserved and high burden of COVID. And so at scale, we were able to create a test program, create a follow-up program, and continue to follow up and look at what were the results of each step. What were the most prevalent symptoms? What were the symptoms that were most predictive of COVID? And how we could monitor asymptomatic versus symptomatic infection, and then look at the impact of vaccines. And we've submitted several papers around those data that we collected. We also use the same platform for doing the largest multi-center study looking at patients with COVID post-hospitalization called the IMPACT study. It was published in Nature Communications 2 months ago. And we were able on our platform through a vast number of surveys over the course of the year following hospitalization to identify 4 distinct phenotypes of long COVID based solely on patient-reported outcomes coming through our mobile technology. So I wanted to leave you with what we think are important lessons learned over all of these different implementations. And I think one of the things that's very important is that we feel very strongly anything that we're able to do in these underserved communities where we know the barriers are high, the challenges are significant, can certainly be applied in settings where there are more resources. But this idea of creating tools and solutions that provide a more equitable approach to clinical research or clinical problem solving, I think really it necessitates the use of tech enablement. So our initial platform goals really were to move from manual paper processes with those community health workers in Texas and build a very easy to use. Our platform, no more than 3 clicks for data capture, integration, and reporting functions. And we have all those built in for state, local, federal reporting functions so that these teams can do their business and scale the number of participants that they can manage significantly through the use of technology. Lessons we learned that are critically important. Don't force the issue on putting your system in. Take what's there and try to integrate and work with it, because people have a hard time changing completely everything. Facilitate the facilitator. I can't express the importance of this enough. We spend an enormous amount of time with nurses, social workers, community health workers, primary care physicians to understand what tools would work for them and how to make technology not be burdensome. And this is critically important for tech to work. Empower the participants. Again, tech should not be burdensome. It should be easy. It should be quick. People don't want to be online or on their phone dealing with their health stuff like they do games. They want to be able to use it, get it done, and have it work for them. Make the data easy through visualization tools. If you're collecting information, give them nice interfaces, whether it's avatars, which we use a lot for symptom tracking, or whether it's visual analog scales, but a variety of strategies for bringing in data and bringing in data that has meaning to them and relates to their functional life. And cultural competency is critically important here. Some of the scales and metrics and tools that are out there and valid ask questions that are not culturally competent. We had a bunch of questions we were working with in North Philly. Some of the metrics that were standard metrics were asking about physical impairment and the ability or lack of ability to be able to golf or garden. This was not relevant to an inner city population. Simplify the complex on the UI UX. Make things simple. 5 questions, not 20, not 200. A lot of investigators want 200. You can usually distill it down to the most important things that people need to know. Automate as much as possible in those workflows. And I think the really important empowering thing now that's emerging is advanced analytical tools that can allow us to automate responses using AI and event-driven architecture. And all of these lessons learned has really allowed us to continue to build these community-based intervention and clinical research programs, understand and gather very critical real-world evidence beyond what we typically see in clinical research, and be able to do it at scale. So thank you very much for your time. I really appreciate it. I'm sorry I can't see you, but I hope that the day was great and that you found this informative. And again, thank you to the organizers. This was a really great meeting from what I could see, and I'm honored to be able to speak here. Thank you.